Today I'm speaking with Dr. David Patrick, who's a medical doctor, an infectious diseases specialist, and a faculty member at the University of British Columbia. He's recently been involved in a research project about the prescribing patterns of professionals in British Columbia, their prescribing patterns for antibiotics. Welcome, David.
Thank you very much.
Could you give us in broad outline what's the context for your research project?
Well, since early last decade, in British Columbia, we've taken advantage of our prescription database system, BC PharmaNet, to track antibiotic use over time. We do it for a number of reasons. We do it mostly because we need to understand our use in an effort to reduce unnecessary use and slow down the selection of resistant organisms. But naturally, cost is an issue too, and governments have an interest in that. Essentially, until this year, we had no information that would allow us to speak to whether the prescription was coming from a doctor or a dentist or another prescribing health professional. And this year, for the first time, we've seen those breakdowns. And I think they're quite informative for me and for our mission in terms of stewardship in BC, but also for our dental colleagues.
So I believe you have a presentation to show us.
Yes.
So let's go have a look at that now.
Let's do it. So welcome to a short presentation on antibiotics in dentistry. This is work we've done at the British Columbia Centre for Disease Control, which holds a contract with the BC Ministry of Health to run a population-based antibiotic stewardship program known as the Do Bugs Need Drugs program. And I do this as a faculty member for the University of British Columbia. You'll also note that we're beginning to share these information with our dental colleagues in BC through a BC Dental Association practice series. In 2013, antibiotic resistance was declared a crisis. Now, it wasn't really new. We've been like the frog in the proverbial pot. As it gets hot, if it was suddenly hot, we would have jumped out, but it's become gradually hot. It's taken a few decades for us to see an increasing amount of resistance among organisms that cause common infections. But in 2013, led by the UK's Chief Medical Health Officer, Dame Sally Davis, people began to blow the whistle on the severity of this problem. The US CDC said there were 23,000 deaths in 2013, similar numbers happening in Europe, and this means with conservative attribution that in Canada we see 2,000 to 3,000 deaths from antibiotic resistance already. But this is really just the tip of the iceberg, because what we're seeing in family practices and probably in dental practices throughout the country are tens of thousands of illness episodes. Physicians see routine urinary tract infections that are harder to treat and routine skin abscesses that are harder to treat than they used to be just a decade ago. And you can inform me as to whether there are similar experiences occurring in dental practice. The picture on the right is of a severe methicillin-resistant Staph aureus skin infection, and this is an infection that needs to be treated with a dwindling supply of antibiotics that remain effective. The real question for us in healthcare is where will increasing resistance take us? Because it's not just a matter of antibiotic resistance making it difficult to treat infections. Resistance jeopardizes the safety of all surgery. Most dentists are surgeons, and so you own this problem. It jeopardizes the safety of transplants, cancer therapy, and really any immunosuppressive strategy, including the very successful ones we're seeing now in rheumatology. It also increases the burden of infectious diseases at population level and the costs associated with it. And very clearly, as illustrated in West Africa recently, poor control of infections can badly hurt economies. And so when we were working with students at the Vancouver Film School to come up with new posters, they came up with this particular poster on the right. Imagine a world where antibiotics don't work anymore. And we need to use these antibiotics wisely so that they can continue to save lives. It's important to remember that there's a two-step in bringing resistance into existence. First of all, there has to be a pre-existing mutation or a pre-existing resistance gene in a population. When we apply antibiotics to that population of microbes, the red microbes here, which would be fairly resistant, are selected for, and they become the final population. So even when we're using antibiotics appropriately, we will be selecting for resistance. But we will accelerate that process quite a bit if we use antibiotics for inappropriate indications as well. Natural selection then is driven in healthcare by antibiotic use in people, in all kinds of healthcare practice, and in our pets. It's also driven by antibiotic use in food production, another area where things are being addressed. And once we have resistant organisms, there are other things that help them get around. We see importation by people conducting health tourism to the Indian subcontinent, for example. We see faster spread in dense populations, and this is true of densely populated cities, densely populated hospital wards, and even densely populated chicken coops. And we see that we can reduce that spread by good hygiene, good infection control in healthcare, and good antisepsis in surgery. To cut to the chase, when we began to take a look at data available from 2010 to 2013 in British Columbia, we could actually see what proportion of all antibiotic prescriptions were ascribed to prescribing professions. Now in BC, in addition to doctors and dentists, we have a few nurse practitioners, pharmacists, and other healthcare providers submitting a few antibiotic prescriptions. But really, doctors and dentists do the lion's share of prescribing. This column here shows that over those 4 years, dentists have been responsible from between 10.5% or so to just over 11% of prescriptions. So a considerable proportion of the antibiotic prescriptions are being submitted by dentists. The good news in terms of longer-term antibiotic use, and this is between 1996 and 2013 in BC, and many other provinces have seen similar trends, is that we've seen a nearly 25% reduction in the rate of prescriptions over population. So this is prescriptions per 1,000 people per day, declining from about 2 in 1996 to just over 1.5 in 2013 for every 1,000 people every day. That's the good news, and we feel that that's been the result to a certain extent of awareness by the public and prescribing professionals of the need to use fewer antibiotics. In human medicine, the areas where we've been able to bring about big reductions have been in upper respiratory infections that do not benefit from antibiotics and in middle ear infections. The bad news, on the other hand, is this blue line is indicating the increase in dental prescribing since 1996. And this term, defined daily dose per 1,000 population, defined daily dose simply means the average dose prescribed to an adult for an average indication. It tracks exactly with prescriptions. And what you can see, in effect, is a 62% increase between 1996 and 2013 from just under 1 DDD per 1,000 population per day prescribed by dentists in British Columbia to much more like 1.6. So that's a considerable increase. And that increase is actually going some distance to blunt the decline we've been seeing from some other prescribing professionals. The real question for me, not being a dentist, not understanding how dental practice is changing, is what is driving this increase? And it's really important to understand what's driving the increase, because it's important to know if this is a changeable increase. I'm going to lay that question out to you, and hopefully this is the beginning of a dialogue that can help us understand it and change it.
David, that sounds like a very significant variation in prescribing pattern between dentists and physicians.
I'd say it is. In fairness to dentists, I think that physicians have owned the lion's share of antibiotic prescribing, and that means that stewardship programs have focused almost entirely on physician prescribing. For example, We've spent a lot of time teaching the public that coughs and colds and flus don't benefit from antibiotics, and reinforcing with physicians that treatment of upper respiratory infections, by and large, don't benefit. It's in those areas where we've seen vast reductions in prescribing in physicians. Middle ear infections, acute bronchitis, sinusitis, that sort of thing. We've not provided the same attention to dentists, but I'm not aware, I don't understand what changes in dental practice might have led to an increase in prescribing over the last decade and a half.
So do you welcome dentists contacting you directly with their views as to why patterns would be going the way they are?
I would love to hear from dentists, and we'll put up my email at the end of this discussion. I think that this conversation begins with understanding what the drivers might be and what may be changeable about them through guidelines, continuing dental education, and even education of patients who are going to dentists along those lines. There may be some parallels with what's had to happen in medicine. For example, most skin abscesses in humans can be managed properly just through incision and drainage. They don't need antibiotics to get better, and antibiotics don't benefit them unless they're very complicated with bad fever surrounding cellulitis. I've heard from some dentists that this may be true of periapical abscesses, but I need to learn from the dental profession where they think the changes can be made.
Dr. David Patrick, thank you very much for opening this very, very important conversation. And we look forward to helping you get the input of dentists and the viewpoints as to why the pattern is as it is.
My pleasure. Thanks for welcoming me here.